Hello, everybody. Thank you so much, Dr. Debraju, for joining us on a podcast with Dawdle. You have a prolific experience in the healthcare industry. You have been a doctor yourself. Would like to request you to introduce yourself for the initial 1 minute, so that the audience understands your experience and the contributions so far.
Hello, good morning, everybody. This is Dr. Debaraj Reddy from Hyderabad. Basically, I am a surgeon and transformed into healthcare leadership roles. So, right now, I am doing many startup projects. So, what I observed in my clinical practice of total around 25 years, being a clinician, being a surgeon, you wanted to do many things, but there are many hurdles because you are always working under somebody and management is above you who are taking decisions for you. I think that is the reason probably motivated me to take a bigger role of healthcare leadership, so that being a clinician I understand the clinician pain points and patient pain points very much, so that we can provide better solutions not only for the patient but for the clinicians, so that their work and their decision making so that will be easy and they can create more precise solutions for the patient, and they can spend more time with the patients with more of empathy and more of connect with the patient. That is the basic idea of my transformation. I think Rishikesh ji has to take the journey next.
Thank you so much, sir. So first question that comes is that why from being a surgeon to kind of an administrator, kind of a role where you are helping a lot of startups. So, for the sake of the audience, who are at a leadership position at various companies, various industries, we would like to understand from you what are the various processes involved while you are managing a hospital. Like, if you can give us a brief overview of the things.
See, first you asked the first question about me from a surgeon to a healthcare leadership role. Of course, it's a very personal choice, right? Everybody want in India when we choose our career initially, na, we don't know all the aspects of that career, right? Our parental and other social pressure. We really don't know where we belong. By the time we realize, we are already gone through our mid of the career. So it's very difficult to change it. That is the reason in India, many people are not exploring it, but that's not the case in the West. But the moment you identify your talent, I think you should ready to take the risk and move on in life. There will be risk involved in a mid career and later career period where change is there, but that's the way the life is all about. So that's in personal point of view. About the hospital point of view, you see, hospital management and patient management is a very complex process. It's not a single. It's not about doctors or nurses. Many paramedical, non-medical person, even security guards, even housekeeping. There are many things involved, and in many departments. Even just for running a hospital, we have to take at least around 30 regulatory approvals. 30 you can see, and then the same goes, maybe around 30 departs may be working. That is the reason 30 regulatory approvals we are taking. Right? So it's very complex process. Patient comes with the hospital with the pain of the disease, and unfortunately goes again with the pain. It's this time with the pain of the billing. So as a clinician, we understand those pain points, and as a healthcare leader, I am exploring how can we make that patient journey smooth from entry to exit to the hospital.
So, sir, from the point that patient enters the hospital, that is called, patient admission, that can be OPD as well as an IPD. What are the various critical processes? Like, say, insurance billing is one thing, maybe, coordination between the nursing staff, ICU management is another thing. So, वैसे, sir, if you can help us understand the few processes which happen within the hospital.
You see, being a doctor, I can easily tell about the medical processes. That's not a problem for me. I want to highlight about the non-medical process also. For
Yes.
example, the moment patient comes, it starts with the parking, right?
Yes.
You have to help the patient attendants about the smooth parking. Then
Yes.
welcome to the hospital from there. Then directing them to the reception or OPD billing counter. In India, OPD instance is to take momentum. As of now, OPT is maximum cash based. That's not at the time instance point is coming. So the moment a patient is get registered, understand and guide the patient to the concerned department where the OPD is there. And this the main question, because suppose a star doctor having many OPDs, many queues, many patients are outlying. and we usually give a slots of around 10 to 15 minutes depending on the department. But the disease is not fixed, right? And the interaction cannot be fixed to the 10 to 15 minutes. In that way, what happens? We have given a slot for a patient, for example, OPD at 12 o'clock.
Yes.
The time may shift to 12:30 because the earlier patient taken more time. But it's not like a system. It's not a fixed process. It's a human body. It's not a fixed like a Maruti car that you can fix the parts, right? You
Yes.
have to listen to the patient. You have to understand it. You have to process it. Then we have to give the what are the best options for that patient. So it takes time. And being a doctor, we have to be very empathetic. We have to listen to them. So we cannot like a process. It cannot be like structured process. It has a subjective. It's very personal process. That's why it takes time. So that the coordination about the waiting time is very crucial because maybe patient in the queue may be very emergency, right? Probably that patient needs consultation before the patients who are already in the queue, right? While taking appointment, the person who is giving the appointment, he is not taking the like the history about the diseases, right? He's just as per the call, as per the list, he's giving the appointment. But sometimes patients who are in the queue in the first, they may wait little more rather than the patient who is the probably senior citizen emergency. These are the, I think, pain points. Still, we are working on it, and probably it needs more departmental coordination between operations, nursing staff, and doctors, so that the thing that is the main thing. Then once the OPD consultation is over, then there are two things: what investigations patient require, uh, whether patient first thing whether patient requires admission or just OPD process. No problem. Patient goes into the admission, then everything will be taken care by the inpatient department. But in
Yes.
patient is not admitted, then guiding them for the necessary investigations or guiding to the pharmacy, or if a patient needs any like pre-operative test before admission
Mm.
and counseling, pre-anesthetic checkup. These are the issues we have to. Then, if the patient is being admitted, then probably we have to take them to the insurance counter, then sending them for approval, whether it's elective admission, emergency admission. So these issues will come. Since as of now, still even in urban India also, patients, many patients are in under insurance coverage. Of course, it's picked up, but
Yes.
in tier two and tier three cities, still most of the patients are out of the pocket patient. So then there is no problem. But the moment insurance comes, lot of documentation, pre-authorization, approval, these things will be there.
What are the main, so we'll not talk about technology, but what are the main challenges that needs to be solved with the help of technology when it comes to hospital operations?
It's a very important question. You see, now with the digital technology like AI, artificial intelligence, machine learning. Earlier, EMR was also there. But the thinking that the point is that we have to it has to be very customized. Number one, I suppose I am running a small hospital. What are the pain points I have? What the digital solutions I require for my hospital? That is very important. Okay, and also the cost factor. Like first is the patient factor. What are the pain points like operational challenges or clinical challenges where the digital technology can help me to smoothen my operations, or to help me to improve my clinical excellence with the help of the technology. That's identifying that is very important because many digital platforms are available in the market, but can all of them cannot, so it like cannot be tailor made. It cannot be like one stop solution for everything. It has to be customized and tailor made. That is one aspect. Second aspect about choosing any digital thing is that about the interoperability and integration with the existing system. Suppose I am going for any AI tool and I already having an EMR system in EMR and hospital management system and packs and lab, all are there. So it has to be integrated with the existing system. This is the main important point because many softwares are coming. I really don't know whether all are being tested and with the government authorities to leave go into the market. Really, that's a very challenging because they have to comply with all the regulatory things like HIPAA, DPDP Act, and probably NABS guidelines. Then only they have to come into the market. So that is the two, like interoperability and integration. Number three is what we choose the reputation of the digital technology provider because ultimately It's not about the technology. It has to solve my problems, and the support after installation it needs, because my staff is hardly understands everything about that digital technology. It's the support, long term support. And other thing, that whether that technology is aligned with my long term vision and my mission about my aspiration, my hospital functioning system. And the last but not the least, since of course it is a costly thing,
Yes.
so ROI also important, a
Yes.
return on investment. But it's not just about financial return on investment, it's about on clinical return on investment, because it has to improve my clinical efficiency, it has to decrease the any potential complications, medication errors, it has to improve the patient satisfaction score, it has to increase the predictive analysis, we can able to clinical decision support system. These are the clinical return on investment, where these all things will turn into financial return on investment later part. But I have to initially take on my clinical return on investment. Of course it will turn into financial return on investment. That's why healthcare is a business, and at the same point it's a service. If we concentrate on business, service part will be hampered, and then there won't be any business also. But if we concentrate on the service part, service will be excelled, and then it will give the more business. As simple as that.
Right. Sir, I will come to one specific thing is that, so a lot of the hospitals have a lot of ICUs in place, and especially in tier 2, tier 3 cities, usually the presence of good doctors is not there.
Right.
And that is where it becomes very difficult for managing the ICU and all those things.
Right.
So there are, technology which is coming in this space which helps in remote monitoring of ICU.
Exactly.
Now we will want to understand from you what are the risks involved and what needs to be done in order to have these remote monitoring system in place inside the hospitals.
Right. This remote monitoring, telehealth, telemedicine, tele-ICUs came,
Yes.
I picked up during our COVID period. But it not only helped in COVID period, but it became part of the our healthcare management system later on. How it is going to help? You see, risks involved are very minimal. Why I tell you? What is tele-ICU? What is remote monitoring? It is monitoring the patient remotely. It is not treating the patient remotely. Let's
Hmm.
understand the difference. Okay,
Hmm.
it is monitoring the patient remotely. It's not treating the patient remotely. The treating nurse is there in the ICU. The treating doctor, at least one doctor, there in the ICU all the time. Right?
Hmm.
Only the experts, like as you said, it's not easy to get the good intensivist, good ICU experts in remote areas, tier 2, tier 3 cities. So in the center city where that expert intensivist is sitting and remoting and monitoring all the patients, he is in turn guiding the doctor who is there in that remote ICU and executing the treatment. So I wish, if there is no technological breakdown, and as long as at least one treating doctor, one qualified MBBS doctor at least present in that remote ICU, and
Yes.
qualified nurses are there, I think risks are very minimal until and unless there is technology breakdown or any other problem. Treatment risks are very minimal. But definitely the patient monitoring and clinical decision support system and the expert advice easily they can get, because one expert can guide many intensivists
Yes.
in many remote ICUs. But at the same time, in a small hospital, small ICUs, they can't export that kind of, they can't afford also. Even if they were ready to go to that place, he cannot afford that kind of expert. So that's why this remote ICUs came. I think they're really doing very good.
And so this also kind of gives an opportunity to good brands also to establish hospitals in tier 2, tier 3 cities.
Yeah, that is the I think next wave of healthcare investment.
Yes.
Because now the tier one cities are overcrowded, overcompete. Many brands, many healthcare chains are already there in the tier one cities, and they can afford, because why tier one cities? Many investments coming into our Indian healthcare system, maximum FDI coming, but they want quick return of money. Right. In tier 2 and tier 3 cities, the insurance penetration is less, and also patient capacity, paying capacity is little less compared to tier 1. That is the reason everybody concentrated on tier 1 cities and metros. Now there is a point of saturation coming and lot of competition. Now there is opportunity lies in tier 2 and tier 3 cities. I think already, I think Narana Yudhayali are concentrating more
Yes.
on tier 2 cities. Now even a very premium brand like Polo, Max also and Manipal also now concentrating on tier 2, tier 3 cities. Probably we require more facilities in tier 2, tier 3 cities rather than tier 1 cities.
Sir, do you think that the lack of insurance penetration is also a blockage from, good brands establishing hospitals in tier 2, tier 3 cities?
You see, so as I told you, though the state, the society, the public think that hospital is not for the business, it's for the service, right? But does the society or the government give anything subsidized to the hospital? No. Then it became a business, right? If the government society not giving the land at a subsidized rate, not giving the electricity, not giving the power, not giving the any manpower, no grants, nothing. So how the hospital will sustain? That is the region. Insurance penetration is very important, and of course it's really penetrating very fast. Many instance companies are expanding, but believe me, most of the instances are under loss. Why I tell you? Because the you see, it's a game of volumes. Suppose 100, for example, 100 patient took the insurance, out of which around only 5 patients require treatment. So
Yes.
what the policy? That money money from those 100 patients being expended on those 5 patients only. Then only the insurance company will make some money. Now what happening? Suppose only 50 patients are paying for the 10 patients, right? So it's not matching the cost and the collected money from the insurance companies and the insurance companies what they are spending. So insurance penetration is very essential. That is the reason I think government, at least for the lower bottom of the period, came with Ayushman Bharat and this thing. That's good as far as the lower bottom of the period. I think even now middle class people now started taking now corporate insurance. By default, many corporates giving insurance to all the employees and their even parents also. I think it's that is the reason as the institution penetration goes deep into, I think many corporate hospitals also will come into the tier 2 and tier 3.
Right, sir. Sir, one of the major issues facing the healthcare system is also the identification of the right doctors or right hospitals. Like, suppose, there is a patient who is looking out to find out a right doctor. Most of the review system is like, most of them are fake. A lot of them are fake, sir. So, this kind of transparency seems to be missing. And, your insights on this, sir, and how can we improve, better discovery of doctors?
Okay, I cannot go with the notion that most of the reviews are fake. I am being a doctor, you can't do that. So my point is, you see, most of the reviews are given by the public from their own mobiles or from their own email IDs, right? And nowadays, when people can make what is the fake review and what is the real review. Earlier, what happens? There is a system of like family doctor system was there, right? It was
Yes.
there for a long time. Even now, also believe me, in even
Tier 2, tier
the
3 cities. It's there.
people believe their RMP, what we call an RMP, is not an RMP. You're not even qualified to practice it medicine. But still, then he is the family doctor for the
Yes.
particular family. Whatever he says, they blindly believe him, right? So that's where the referral system started. So-called family physicians or RMP, they guide the concerned patient to go to the particular doctor. So what happens? That doctor will say, refer to the patient to the concerned doctor, which he knows or which he is tied up or the concerned hospital. So the best thing about that is that it's word of mouth, right? You know many people, right? Along even society, friends. So it's a very closed system. Like we don't have any government system of no, referral tier. So ultimately, it's an individual choice because he has a lot of persons to where to go, and
Hmm.
many of them take the like a review system, and many of them ask. For example, I tell you,
Yes.
many of my software friends
Huh.
they can go with the reviews, right? But they don't go with the reviews because
Hmm.
they know me personally. They ask me, this is the problem I have, where to go, whom to go. I think that is the best way. You have to believe somebody. If you don't believe that reviews, you have to believe somebody in your known circle. And at the end of the day, ultimately, the doctor service, you can be fooled one time, right? Second time, how a doctor, how the hospital is doing. I think you are the right person to spread the awareness and to give the real review rather than fake review, so
Yes.
that the other people can benefit with that.
Right. Now, sir, since you have a very prolific experience, tell us about a few technology, implementations that you'd have seen in the hospitals, which is really kind of helping the hospitals.
So what I will tell you about, you already mentioned about ICU. What happens? Ultimately, there is a lot of data, lot of clinical parameters.
Yes.
Doctors are also humans. It's
Mm.
not that they don't know things at that time. Probably they are not in a mental and physical condition to take the right decision with so many patients and so much of data to analyze, so much of physical reports to see. So what the system is now doing is, suppose one AI tool came and we try to integrate with the EMR, right? EMR are already integrated with the PACS, pharmacy, everything, and also the patient monitoring. So
Mm.
what happens? This AI, what exactly do? AI is not going to treat the patient.
Yes.
It can analyze all the investigations, all the imaging, and what the medications patient already taking, because it's already there in the MI, and so many years of clinical data, it is access. AI can access all the breakthrough inventions, all the medical science done so far. It can take the knowledge from everything till done, because everything in the web, right? AI takes what after, it takes the data from the particular patient, and
Yes.
with all the knowledge in the web, in the world,
Mm.
it compares all the knowledge where to fit that data, and it recommend the best treatment modality or best investigation modality. It can guide the doctor. Ultimately, the doctor has to review that recommendation from the AI tool, and ultimately he is only executing the treatment. So what it really helping the nursing staff or doctors to analyze the data and to decrease the written work. Earlier, nurse keep on filling all the vitals, all the notes about the patient. Doctor keep on writing the files. That's why he doesn't get that much of time to spend with the patient. So now the technology reduce the written data, and also helping the analyzing the data, analyzing the vital parameters, and also helping the nursing staff and doctors to spend more time with the patient rather than the written work.
Of AI. Even on the insurance side, sir, there are a lot of products which has come which actually streamline insurance processing and helping the hospitals.
You
उन
see,
पे क्या फीडबैक है सर आपका?
देखो, द रियल थिंग इज दैट, देखो आज मैं बता, इंश्योरेंस पेनिट्रेशन इतना ज्यादा नहीं है, राइट? तो क्या होती है, हॉस्पिटल का भी प्रेशर है, तो हॉस्पिटल क्या करती है, आई एम नॉट सेइंग दैट हॉस्पिटल यूजुअली इन्फ्लेटिंग द बिल्स, बट द इंश्योरेंस कंपनी थिंक दैट बिकॉज द दिस पेशेंट हैज पेड ओनली दिस मच ऑफ प्रीमियम
हाँ.
एंड हिज लिमिट इज दिस मच, बिल इतना कैसे हो गया? तो व्हाट दैट इंश्योरेंस अंडरराइटर विल डू, ही विल ट्राई टू रिड्यूस द बिल, so that what the insurance do. So what this AI or the AI tools can help this, कि जो coding system है, तो what are the procedure, what are you do, it's everything being coded, right? So what are procedure you done, it's be already coded, pre-coded with the approval of the insurance company, and for that code what are the approval amount, it is already fixed before, उसमें ज्यादा मैनिपुलेशन की। तो ये क्या होता है, ये कोडिंग सिस्टम विद एआई टूल्स के साथ, तो मैनुअल एरर हो रही थी बिलिंग, पहले मैनुअल जो बिलिंग में एरर हो रही थी वो कम हो गया, सिंस ऑलरेडी कोडिंग सिस्टम, इट्स द सिस्टम बेस्ड बिलिंग राइट नाउ। तो इंश्योरेंस कंपनी को क्या हो गया, जो डिफेक्ट्स पकड़ना भी मुश्किल हो गया, क्योंकि इट्स ऑलरेडी एवरीथिंग इज ट्रांसपेरेंट। इसमें ज्यादा मैनिपुलेशन की गुंजाइश नहीं है। पहले क्या होता था, जो मैनुअल बिलिंग में होता था, जो दो प्रकार का, जो पैकेज बिलिंग और मैनुअल बिलिंग में क्या होता है, उसमें सब्जेक्टिव होती है, राइट? उसमें फिर ज्यादा मैनुअल वर्क भी होती है, एट द सेम टाइम इट्स मोर वर्क फॉर द इंश्योरेंस कंपनी टू फाइंड आउट द credibility of that bill. Now everything is recorded with the coded system of billing. I think that streamline, it is helping both. It's helping the hospital also to get more revenue. It is helping the insurance companies so that उनका जो underwriting process थी, जो claims को process करना, उनका manual efforts कम हो गए, तो उनके लिए भी जो billing approval time जो होता है काफी reduce, and with that system what happens, more people will come into that insurance system, right? जो कंपनी बहुत ज्यादा जल्दी इंश्योरेंस क्लेम अप्रूवल, पेशेंट बहुत जल्दी अगर डिस्चार्ज हो पाता है, दैट ब्रांड वैल्यू एंड ब्रांड पोजीशन ऑफ दैट
Yes.
कंपनी, इंश्योरेंस कंपनी इंक्रीज, मेनी पीपल विल टेक दैट इंश्योरेंस कंपनी, more number will come, ultimately it will turn into a profit.
Right, sir. So there are a lot of market aggregators that have also come into place, so who basically kind of help a patient streamline their journey of surgery. They, a lot of the doctors don't take them, have very negative views about them, in terms of the quality of services that they are providing. And it's also told that hospital and healthcare is something which is built on trust. There are two things: banks and hospitals. So banks and hospitals, both of them are built on trust. So what are your views on those aggregators, and what more they should do in order to make sure that they are helping the existing infrastructure grow?
देखो, any business aggregators mainly aggregators same for doing the business, right? We
Yes.
have to understand that they are not the direct service providers. It's very clear. अभी आप एक सिंपल सी एज ए लेमैन की तरफ सोचो, पहले क्या था, पेशेंट पे करता था, सीधा इधर डॉक्टर को जाती थी या हॉस्पिटल को जाती थी, राइट? सो उसमें क्या हुआ, तो क्वालिटी ऑफ सर्विस मेंटेन होता था, क्योंकि डॉक्टर को भी पता है, हॉस्पिटल को पता है, इतना एक्सपेंस हुआ, पेशेंट इतना देगा। अब अगर एक पेशेंट एक एग्रीगेटर का थ्रू और कोई डॉक्टर के पास या कोई हॉस्पिटल के पास जाता है, एग्रीगेटर तो फ्री में तो सर्विस करना है, ही विल कीप हिज मार्जिन,
Right.
राइट? अल्टीमेटली का खर्चा है, इट विल पेशेंट
Hmm.
पहले भी पेशेंट ही पे करता था, अभी भी पेशेंट ही पे कर रहा है,
Hmm.
लेकिन अभी कुछ मार्जिन एग्रीगेटर के पास चले गई, राइट? तो हॉस्पिटल का जो रेवेन्यू कम हो गया, लेट्स टेक इन वेरी क्लियर इन बिजनेस सेंस, हॉस्पिटल रेवेन्यू कम हो गया, तो हॉस्पिटल क्या सोचेगी, इस पेशेंट में मैं इतना खर्च कर रहा हूँ, जो नॉन एसेंशियल थिंग है, एसेंशियल थिंग एज ए डॉक्टर कोई हॉस्पिटल नहीं करती, नॉन एसेंशियल थिंग वहां मैं इस पेशेंट पे कर सकता हूँ।
Got
पेशेंट अल्टीमेटली जो पेशेंट पैसा दे रहा है उससे ज्यादा तो खर्च नहीं करेगी पेशेंट, राइट?
it.
सो उससे कम ही तो खर्च करेगी, सो दैट हॉस्पिटल का एक्सपेंस बीजे, एंड एट द एंड ऑफ द डे ही हैज टू मेक सम प्रॉफिट। व्हाट आई मीन टू से दैट एज ए क्लिनिशियन माय एज ए व्हाट एग्रीगेटर्स कैन डू, लाइक इट्स ए वॉल्यूम बेस्ड बिजनेस, लाइक जैसे पहले बताया, किसको पास जाना है नहीं जाना है,
Yes.
एग्रीगेटर के पास सारे डाटा है, राइट? They can guide the right patient to the right person. That's very important, depending on the patient paying capacity, to the right person and to the right hospital, right? Depending on the insurance eligibility of the patient and paying capacity of the patient. What अगर आप छोटी एलिमेंट के लिए बड़ा हॉस्पिटल चले गया, तो इट्स नॉट लाइक नॉट रिक्वायर्ड, राइट?
Yes.
So our aggregators should like look for other revenues, just rather than this service fee from the hospital. They should look focus on other revenues from advertisement, because
Hmm.
now even every digital platform is getting some revenue from the advertisement, right?
Yes.
They can promote the good hospitals, good
Uh,
doctors with good reviews, so that ultimately they will get that kind of revenue from them, so that the burden on the patients or the hospital will decrease. Then I think there will be no question of quality compromise. But as long as the aggregators are there, so ultimately aggregators has to spend a lot of money on digital platform and digital campaigns, right?
hmm.
So ultimately he has to recover that money. Of course, health is a state subject. इंडिया में वो पूरा अनफॉर्चुनेटली आ पाई नहीं है, but anyhow now government is very proactive, at least they are doing something for the bottom of the pyramid, I think, and ultimately it will come to the middle level and upper level also. Of course aggregators are necessary, I'm not saying that, because so many doctors, so many hospitals are coming, and
Yes.
it should be a like win-win situation for both the patients, for the hospital, and also for the aggregator.
Right, sir. Sir, my last, in the part of the discussion, we like to discuss with you about mental health. So a lot of the good hospitals have very, good facilities for, anything related to physical health, say whether it's laparoscopy or, different things. But when it comes to mental health, the domain is completely different. I am yet to say see a Manipal or Apollo having special teams where they are guiding the patients or consulting the patients on mental health aspect. But as you know, sir, these days mental health is almost an equal a problem than that of physical health, especially in the younger generations and even the mid-age people.
I can tell it's very important question. It's not a bigger problem. It's not a equally important problem. It's a bigger problem, I will say. It's turning into an epidemic. I word epidemic. The unfortunate thing is that society is not recognizing, authorities are not recognizing, but it's spreading. Can you believe one among us, if one among four people is under depression?
Yes.
ये कोई मामूली बात नहीं है।
Right, sir.
हर फैमिली में अगर 4 जन है, उसमें एक बंदा डिप्रेस्ड है।
Hmm.
But the unfortunate thing is that neither the patient knows nor the family knows.
Right. Yes. Yes.
वो क्योंकि वो मेंटल हेल्थ का स्टिग्मा अभी भी है, पूरी तरह गया नहीं,
Right. Yes.
राइट? क्योंकि देखो, पहले इनकम स्ट्रीम्स बहुत कम थे, फैमिली में क्या होता था, एक दो बंदा कमाते थे, बाकी सब लाइक मेहनत करते थे, जो भी चलता था, लाइक अर्निंग ऑप्शंस आर मेनी, बट एट द सेम टाइम जो डिजिटल मीडिया का जो रिवॉल्यूशन हुआ, इट्स
Yes.
टेकिंग लॉट ऑफ टाइम फ्रॉम अवे फ्रॉम अस,
Yes.
दैट इज वन। नंबर टू, कंपैरिजन ज्यादा हो गया,
Hmm.
एक ही घर,
Right.
तो ये डिजिटल मीडिया फोन के इस्तेमाल, आप अपना करीबी दोस्तों को भी नहीं, अरे व्हाट्सएप में चैट हो जाती है, वीडियो कॉल आ जाते हैं, पर्सनली क्यों मिलना, राइट? इससे क्या होता है, हम लोग का जो सुविधाएं जैसे बढ़ते गई, हम लोग कनेक्शन से दूर हो गए, लाइक इमोशनल कनेक्शन से दूर। किसी व्हाट इज मेंटल हेल्थ, यू आर नॉट इन ए पोजिशन टू शेयर योर प्रॉब्लम फ्रीली विद समबडी, दैट इज
Hmm.
फर्स्ट थिंग, राइट?
Hmm.
एवरीबडी हैज द प्रॉब्लम।
Hmm.
कई कई बड़े लोग, I should not name in a digital and public platform, why many suicides happen.
Yes.
That is the boldest thing one can do.
Yes.
It मानना कोई आसान बात है,
Right.
the boldest person on this earth. But at the same time, he not finding somebody to
Yes.
share that problem
Right.
at that moment of time.
Right.
अगर उसको एक बंदा मिल जाता, what he is going through at that moment of time, उसका आधा टेंशन तो वहीं खत्म हो जाती.
Right.
Probably he will come out of that situation, right? Then he will lead his normal life. So वो सब क्यों हो गए? कि जो हमारा जो पहले दोस्ती का कनेक्शन थी, सोशल कनेक्शन था, अपना फैमिली गेट टुगेदर थे या सोशल गेट टुगेदर थे, है ना, ये अच्छे थे, तो उसमें वो जो शेयरिंग शेयरिंग एंड केयरिंग पार्ट थी वो ज्यादा थी। अभी शेयरिंग एंड केयरिंग कम हो गई है, एंड सिंस द यू आर एक्सपोज टू ईच एंड एवरीथिंग व्हाट इज हैपनिंग इन द वर्ल्ड, एंड मोर अबाउट नेगेटिव थिंग,
Yes.
पॉजिटिव थिंग सोशल मीडिया में न्यूज में,
Both come. Right.
है ना, नेगेटिव
Yes.
थिंग्स ज्यादा आता है, क्योंकि जो
Yes.
पब्लिक जो दिखता है वो दिखता है, पब्लिक जो देखना चाहेगी मीडिया पे वही दिखाएगी, राइट?
Yes.
दीज आर द थिंग्स, एंड आल्सो कैरियर प्रेशर, पीयर प्रेशर, कि बहुत जल्दी सेटल होना है ना, बहुत जल्दी पैसा कमाना है, ज्यादा कमाना है, अभी लाखों में नहीं, करोड़ों में कमाना है, बट पैसा कमा रहा है, उसको इस्तेमाल करने के बाद उसके पास टाइम नहीं होगा,
Right. Right.
उसका जो हेल्थ केयर करने के लिए, अपना खुद को केयर करने के लिए टाइम नहीं है. So these are the things I think we are going away from our self care and family values, but still then we have our Indian culture में अभी भी कुछ family values बचे हैं. So I think we need to monitor our children at least till the age of 15 or 18. These are the reasons, more they spend more on the digital media, they will be more lonely and more mental health problems come. The more they spend time in the grounds, family, अपना cousins के साथ, दोस्तों, उनका mental health problem automatic कम हो जाएगा.
Yes.
This is the issues.
Right, sir. Great, sir. This was a great discussion and very insightful one. I think we covered right from the operations that happen within the hospitals, and we closed it on a very important issue of mental health, which actually needs, deserves more attention. And I think a lot of that can be solved if we actually, as you rightly told, sir, if we actually maintain our culture. The culture that we came from. We should not try aping any other culture. Just for the sake of following it.
In closing remarks, you
Yes.
see, technology is here to help the doctors, to help the hospitals. Technology is not here to replace the doctors.
Yes.
ठीक है, तो वो डॉक्टर को हेल्प करने जो डॉक्टर्स बर्नआउट थी, डॉक्टर टाइम जो मैनुअल डॉक्यूमेंटेशन में, बाकी टाइम में जो ज्यादा, सो दैट people will get more empathetic care, more practical care, and the advancement of technology. So both my father and my brother were there, but they were thinking that she was sleeping. She's a diabetic. Both of them could not realize that she's in diabetics. Though my father uttered it, so the moment I got the symptoms, I call a phone call from my brother. I understood. Did you check mother's sugar? Okay, so sugar came very low at 25. So already into hypoglycemia. Then I shouted and she rushed to the hospital. My point, I say बहुत elderly people, lonely people, कितने जगह पे रिमोटली है, उनकी फैमिली, बच्चे कंट्री में सेटल्ड है, डायबिटिक है, रात को खाया पिया ठीक से पता नहीं, सुबह शुगर की, उनका बीपी कितना है, पल्स कितना है, शुगर कितना है, तो टेक्नोलॉजी, तो उससे क्या होता है, ये जो मेनी जो लोनली एल्डरली कपल है ना, इट्स ए वेरी गेम चेंजिंग
Yes.
फॉर देम. So I think many lives can be saved. So I don't know whether you feel it right to say it as emotional I said about my family, but
They said this is
directly or
very true
indirectly,
actually.
I think we need to get this public awareness.
Like,
जो पहले continuous glucose monitoring हुआ, at least once in a while पाया नहीं पाया, pulse कितना है, BP कितना है, sugar कितना है, जो elderly people है, heart patients है, sugar patient है.
yes,
I think these technologies is going to be a real
yes,
game changer. They can be connected with their family
doctors
members or the
directly.
family doctors. That's
Yes,
it.
yes.
Okay.
Family doctor, or sir, even hospitals can provide this
Yeah,
facility.
definitely. Because ultimately, that patient is following some doctor in a hospital, right?
Yes,
So if it is connected with the central monitoring system of
yes,
the hospital, that red flag will come. I think somebody even sometimes even ambulance can go and pick those
yes,
patients, right?
yes, exactly, sir.
Many things can be done.
Yes,
Yes.
yes. And this is a very nice one, sir. Thanks, sir. Thank you so much. I will be in touch, sir.
Nice to talk to you, Mr. Rishikesh. I think this is a never-ending saga because I told you we hardly discuss about 5% of the complex process of
Yes,
the healthcare and hospitals. I think now technology coming in a big way. At the same time, the affordability is an issue.
yes,
Small hospitals not able to afford, right? So that is an issue. I think we need more grants, more CSR funds, more
yeah,
government involvement to upgrade the technology, and it has to be made mandatory. At least हर हॉस्पिटल में EMR होना चाहिए. As
yes,
simple as that. Otherwise उस हॉस्पिटल में मैन्युअली कौन क्या लिख रहा है, कौन जाके ऑडिट करता है. It's
yes,
very easy if you have EMR, so that AI can audit the EMR, and what are the loopholes in that system can easily find out, right? Manual audit is very tedious thing. I
mm,
think government has to incentivize and sensitize this issue. Slowly and surely all the hospitals should have at least EMR.
yes,
यही तो बात छोड़, एटलीस्ट ये कंपलसरी हो जाना
ah,
चाहिए. Probably I am seeing in next 2 to 3 years and maximum 5 years by 2030, each and every hospital should be EMR only.
yeah,
No manual documenting. Everything should be EMR. Then only this we can leverage the AI and other technologies,
yes.
right? We have to integrate. Okay. Thank you. Nice talking to you, Rishikesh.
Thank you so much, sir.
Oh,
Thank you.
welcome. Welcome. Bye bye.